Good evening, everyone. Thank you for joining us this evening on this Hot Topics clinic from NB Medical. It's great that so many of you have given up a bit of time on a Tuesday evening to come and join us. I know what you're thinking. I'm missing Bake Off for this. Yeah, me too. But it's okay. It's on catch up. It will be fine. We can all see who wins later on this evening. In the meantime, we are going to talk about inflammatory bowel disease this evening, and this clinic has been put on in conjunction with Crohn's and Colitis UK, who have an obvious interest in this area. So very quick introductions, and then we'll get back down to business because we've got a lot to cover in 1 hour. So if you haven't met me before, my name is Neal Tucker. I'm a GP in Oxford. I spend half my time doing general practice and the other half of my time working with the NB Medical team. I mostly do the Hot Topics course. I also do the Hot Topics podcast. If you're into podcasts and you want to stay up to date, come and join us for that. Just so that you kind of know where we're at this evening. So I have a personal interest in this because I was diagnosed with ulcerative colitis about a decade ago. And I'm happy to talk about that and answer any kind of questions. I'm very aware that the inflammatory bowel disease is a lot of different things for different people. So my experience will be very different from your experience or your patient's experience. But equally, I'm sort of happy to share a little bit of that. But I'm also well aware that we've got sort of quite a lot of time constraints today. And what I want to talk about is not about me tonight. It's about how we can broadly apply some principles to helping our group of patients who have inflammatory bowel disease. So joining me this evening is Dr. Siobhan Becker. Siobhan, how are you?
I'm all good. Thank you very much, Neal. Lovely to be with you. Thank you very much. My name's Siobhan and I'm a GP as well, like Neal, and in Oxford as well. That's just sort of coincidental. We don't all come from Oxford. I've been a GP for 20 odd years. My personal experience comes from being a parent of a teenager with ulcerative colitis, which gave me a crash course in a topic that I thought I sort of vaguely knew about, and it rapidly became apparent that I really didn't. So I've had to have a bit of a crash course in doing that. I also am director of the mental health course for Hot Topics and also the nurses course. And I present obviously on the Hot Topics course with Neal. I'm here to answer all of your questions this evening. So you'll have already seen, I've said good evening to you all in the Q&A box. Please do let me know how you are doing today, how your day has been, and then just ask any questions as we go along. Tell me what's been going on. Tell me maybe some of your own experiences with your patients, maybe what your local services are like. And then we'll have a little roundup a couple of times throughout the evening to sort of address all of your questions en masse. Everything's completely anonymous. Please do say anything. There's no question too small or too big. And if you're sharing a personal experience, I won't obviously name you or anything like that. But please do get in touch. We really want to hear from you, and it'll be really helpful and helps us to all enjoy the evening together. So I'll hand back to you, Neal, because I know you've got lots to cover, and we'll see you all in a bit.
Great. Thanks, Siobhan. Yeah, let's try and make this a really interactive evening. So do pop your questions or your comments. Please share your experiences of managing this condition. We've got several hundred people on tonight. So I dare say that maybe more than one of us, just by the odds, probably have inflammatory bowel disease. You don't have to talk about it tonight if you don't want to. But if you do want to share, then please do. And I'd be very interested to hear your experiences. So it's an increasingly common condition. By the end of this decade, around one in 100 people will have a diagnosis of inflammatory bowel disease. This has been steadily ticking up over the last few decades, and we don't really understand why. But we just see this kind of like relentless increase in the incidence. So obviously the main types are ulcerative colitis and Crohn's, and we'll be focusing on those this evening. But also don't forget there's things like microscopic colitis. We talked about that on the Hot Topics course before. So you'll see maybe 2 or 3 years ago, we've done a topic on that in the Hot Topics book if you want to check that out at some point. You can also get this indeterminate colitis or IBD unclassified conditions. That's just where they don't neatly fit into boxes, because actually the boxes that we make are somewhat arbitrary and the body doesn't always conform to those boxes. So it's a huge topic. Tonight we're going to focus on the diagnosis and the growing importance of stool tests and diagnosis. And then we're going to talk about management of flares in the community and how we can follow some simple processes to try and help our patients with that from general practice where appropriate. And then we'll very quickly sort of finish up with some further resources, and that will take us up till 9 o'clock. We're going to kick off with a couple of quick polls. So let me ask you this first question. How confident are you at identifying inflammatory bowel disease from the presenting symptoms and signs in your patient? So 4 options here. If you've joined us on these webinars before, you'll know how to do this. Just to the left of each of the answers, you'll see a little circle. Just click on whichever one you feel is most appropriate, and then that pings your answers in to us, and then we kind of collate them on the next slide. So A is very confident, B somewhat confident, C not very confident, or D very poorly confident. How do you feel about identifying inflammatory bowel disease based on your symptoms and signs in your patients? Just give you a few seconds to get those answers in. Are you guys very technically savvy this evening? I can see, because you're all over these questions. Okay, let's have a look. Okay, so somewhat confident. All right, well, let's see if we can, that's the main one. Let's see if we can improve on that tonight. And how confident are you in using the most appropriate investigations for inflammatory bowel disease in your patient? So same again, A, very confident, B, somewhat confident, C, not very confident, or D, very poorly confident. Where do you sit in this? I'm sure that we all have some experience of, and we all have some, we'll all have had patients and maybe even some training in this. So I'm sure some of it, mostly we'll have some idea about what's going on, but it'd be interesting just to know where you kind of sit in looking into potential IBD a bit more. Whilst you're just getting your questions in, I'm just mindful. So I know I have a diagnosis of ulcerative colitis. That makes me somewhat confident in managing my own condition, but equally, that's a very different scenario from someone who. So I've got relatively minimal disease, which is fairly well controlled most of the time. I don't need biological therapies or anything like that. That's a very different scenario. I'm not an expert in biological therapies. I haven't had to have any operations or anything like that. So kind of, just keep it in perspective. Right, let's have a look. Okay, so again, so somewhat confident is coming out sort of top. Good, well, I'm glad you're here then. As we go through this evening, we're going to have a couple of cases to kind of like in our learning around. And Sarah is a real case, actually. It's not her real name. This is not her real picture. But Sarah is a real case. So 23 years old. She'd finished university, looking for work, very stressful period of her life, because this was kind of just coming into the pandemic, really hard to kind of get anything done. She eventually, when things opened up, started a job in retail, just as kind of as a bit of a stopgap to getting her sort of foot in the ladder of the job that she had been trained to do at university. And then she started getting these GI symptoms. Hadn't really had any noticeable GI symptoms in the past. And they were fairly nondescript. They were often linked with eating. So intermittent stomach pain, sometimes excruciating, bad enough that she was doubling over. So that's pretty unpleasant. But intermittent stomach pain, frequent bowel movements after meals, sometimes had a bit of pain on defecation as well. And so most of the symptoms were revolved around having food, but then they became increasingly troubling over several months. She also started losing weight, whether that was the underlying disease or whether that was just the fact that she didn't want to eat as much because it's driving her symptoms. Who knows? So she went and saw her GP, and given that history around food, they made a presumptive diagnosis of irritable bowel syndrome, and very reasonably ordered some blood tests. So these were her blood. So her hemoglobin is 120, CRP is less than 5, and her celiac screen was negative. So all kind of routine stuff that we would typically do in this kind of scenario. So here's a few questions for us. Have we done enough to exclude inflammatory bowel disease? Would you want to request any further tests at this point? Or maybe would you even refer at this point? So let's do another poll. So here we've got Sarah with her increasingly troubling gastro symptoms. What would be your next step in managing her? So would you A, reassure, encourage dietary modification for probable IBS, obviously safety net and follow up and see how she gets on? Would you B, check a fecal calprotectin at this stage? Would you C, refer for direct access colonoscopy at this stage? Or would you D, refer to gastro at this stage? How would you approach a case like Sarah? I dare say that you've all had, that you've all had some of these. Okay, let's have a look at your answers. Okay, well, this will be music to my ears and probably music to the ears of the people down at Crohn's and Colitis UK that everyone wants to check, or pretty much everyone's thinking about checking a fecal calprotectin. So what happened with Sarah is what happens, maybe less so now as we get greater access to stool tests, but Sarah was told that she had no inflammation. The CRP was normal, and so they felt that it was most likely to be irritable bowel syndrome. She was encouraged to try dietary modification, but things just kept on getting worse. And so at the next follow-up appointment, a few weeks later, she actively asked if it could be Crohn's disease because her cousin had a diagnosis and had very similar presentation. And she was told that was unlikely. Continue to try the IBS measures. A few weeks further down the line, further appointment requested by her, and then she specifically asked, "Can I have a stool test, please?" And so I think probably in that situation, most of us, unless we have a very compelling reason to decline it, most of us would go, "Oh yeah, okay, let's do a stool test." And so we sent off a fecal calprotectin, and it came back as 800. So that is a very positive result. And she was then subsequently, of course, referred to the IBD clinic and diagnosed with Crohn's. That whole process from when she started symptoms was over a year. And so I think the case of Sarah just highlights the utility of a simple stool test to help us identify that intestinal inflammation and hopefully benefit in aiding earlier diagnosis. So as we now know, with many inflammatory diseases, there certainly is a benefit of early diagnosis and early treatment, particularly so with Crohn's disease. Of course, once you have had part of your small bowel taken out because of disease, you cannot put that back. So early disease can prevent quite significant morbidity. The problem, of course, is getting the diagnosis. So as we all know, all diagnoses are easy when all the classic features are present, but we also know day-to-day general practice, it rarely works like that. So particularly in the early stages, the presenting features may be absent or they may be vague. And I haven't got time to go through all the main sort of key presenting symptoms tonight. But of course, diarrhea is is the most common symptom of inflammatory bowel disease. But just be aware that even then, it may be absent, particularly in children. And even you can get constipation. So for years and years, because I was really slow getting my diagnosis, that was my own fault because I ironically don't like going to doctors. But I had constipation for many years, and that was that was driven by my inflammatory bowel disease, which certainly threw me off the scent for quite a while. So diagnosis is difficult with symptoms and signs, and that's why many of us might find that tricky, unless it's kind of barn door, yeah, I've got multiple bloody stools today and I feel absolutely terrible. So investigations definitely do help. So we can use them to discriminate between possible IBD and IBS. And of course, we also use them to exclude other differential diagnosis. So traditionally, the sort of blood panel that we use is quite minimal here. So we want to do a full blood count, a CRP, a celiac screen. We also want to do a stool culture at this point because it may be that this is actually infection. It may be that because of their inflammatory bowel disease, that makes them more likely to get GI infections. And so it's actually not uncommon that someone will also have some kind of stool infection on top of their inflammatory bowel disease. So you certainly want to check that. There's also other sort of routine tests that that are generally recommended to exclude other causes. But the key here is that CRP, because that's what we're all thinking. This is an inflammatory condition. You would expect an inflammatory marker to go up. And sometimes it does. But we can't be reassured by a normal CRP. So blood-based inflammatory markers have got poor accuracy. False negatives certainly can occur. So again, my story is not everyone's story, but on the day that I was diagnosed, so in the last 24 hours, I'd had 8 bloody stools prior to having my scope and starting on some steroids. Did my CRP that day completely normal. It's always been normal throughout the last kind of 10 or so years since I've had a diagnosis. So for me, it's not a good marker of what's going on. Of course, if you've got a positive result, that's helpful, but of course it doesn't localize inflammation to the bowel, so it could be anything that's driving that increased CRP there. So better tests are now available, and thankfully they should be pretty easy to access for us as well. So the stool tests have better sensitivity and better specificity than blood tests, and of course the test of choice, if you're thinking about inflammatory bowel disease, is fecal calprotectin. But we're also going to have a little think about the role of fecal immunochemical testing. Very topical, because if you've seen the news over the last few days, if you're in England at least, then they've made some quite significant recommendations for the use of fecal immunochemical testing in patients with suspected colorectal cancer. Let's park that for a moment and stay with fecal calprotectin. So I think we're probably all familiar with this recommendation now. Came out almost a decade ago now. I can't believe it's that long, but this was a nice guidance, and they recommended that we use fecal calprotectin to help differentiate IBD and IBS. So it's recommended as an option to support clinicians in children and adults with recent onset lower gastrointestinal symptoms for whom specialist assessment is being considered, i.e. we're not entirely sure what's going on. We might traditionally have thought about referring someone so that we can get a bit more information, a bit of specialist input. We can get the investigations maybe that would clarify that for us. Well, now they're saying, let's do a fecal calprotectin first, and that certainly can help. And this is the test of choice as long as cancer is not suspected. So calprotectin is this protein biomarker. It's secreted by immune cells that are activated due to inflammation in intestinal cells. You then find it sort of secreted in the feces, and it's a high sensitivity test. So it's useful as a rule-out test for inflammatory bowel disease. The only kind of little caveat there is if you're thinking about it, microscopic colitis in older people, it's not always that sensitive in that group. So for like older people who've got persistent diarrhea, they're going to need a scope. I mean, most situations we'd be thinking they need a scope anyway. Well, at least in the last few days before we started doing fit tests on everyone. But in this context, using fecal calprotectin for microscopic colitis is not as good. But for Crohn's and for ulcerative colitis, it's very good. It's got a lower specificity, so it's not a rule-in test. It obviously alerts us that we need to investigate this more, and people will then go on and need to have a confirmatory colonoscopy. It's just worth noting there are some things that can increase the level of calprotectin. So medications, PPIs and NSAIDs can increase it. I feel like whenever we say there are some medications that can make other things more difficult or bad or trigger stuff off, it's always PPIs and NSAIDs, isn't it? It's a miracle we still prescribe them. But they can increase your calprotectin levels, and also other conditions, particularly bowel conditions like diverticulitis and gastroenteritis, could also elevate that result. Also worth knowing, it is a quantitative test. So the higher the levels, the greater the likelihood that this is inflammatory bowel disease. And that can be useful to guide the speed of the referral that we need to make. So this is, we call it a new fecal calprotectin pathway. It's not that new. It's been around for a few years. It's been sort of suggested as part of the NICE, sort of like as the sort of some of the extension of that NICE guideline. But over the years, it's kind of been fleshed out. We've got more information about it now. So at the top of this, which is cut off from our little flow chart here, is the bit where we've already examined the patient. We've talked about their symptoms and signs. We've done our initial blood tests. We've done our stool test, do the stool culture to exclude infection. And then we're thinking about fecal calprotectin. And this is helpful just to give us an idea about how we should approach high levels, low levels, and then this intermediate in-between levels. So it just gives us a very simple strategy for approaching this with our patients. So if they've got a fecal calprotectin level of over 250, almost half of that group will have inflammatory bowel disease, because the risk is high, and also because the higher your fecal calprotectin, the greater the chances that you've got severe disease. Then in that group, they would recommend urgent referral so that they can get the tests and the input that they need as soon as possible. So that's 250. If it's between 100 and 250, it's this kind of like indeterminate level. And so they recommend repeating it within 2 weeks. You don't need to leave it very long, because what they're really trying to just look at is this kind of interpersonal fluctuation that you get in calprotectin levels. If you repeat it and it's still the same, then they are still at increased risk. 1 in 8 of those will have IBD. If it's under 100, then you're basically going into this other part of the flow chart. And in that under 100 group, 98% of them will not have inflammatory bowel disease. The vast majority are then going to have irritable bowel syndrome. So that we just so we're all on the same page, and this is kind of like the ultimate safety net, basically. If symptoms persist and your fecal calprotectin's anything over 50, or your age is over 50, or despite second-line irritable bowel syndrome therapy, things are still not getting any better, basically you've got ongoing symptoms, ultimately you're going to need to refer that patient to have some clarification, because the bottom line is none of these tests are perfect. What about the role of fecal calprotectin? So, of course, fecal immunochemical testing. So, calprotectin is used in a different context. So, fecal calprotectin is not recommended to exclude bowel cancer. It can identify cancer a bit, but it's not the preferred test for that. FIT testing is. And so, as patients get older, then calprotectin testing becomes less appropriate because of the increasing cancer risk into older age. And the suspected cancer guidelines from NICE, apologies to those who are in Scotland, Northern Ireland, Wales, who are not using these NICE suspected guidelines, but they kind of give us a bit of an idea about sort of where most of us are going with this. So in the NICE suspected cancer guidelines, they updated them at the end of last year to offer a quantitative FIT test to assess for colorectal cancer in adults without rectal bleeding who are aged 50 and over with unexplained abdominal pain and weight loss. If you're under 60 with a change in your bowel habit or iron deficiency anemia, or you're aged over 60 with anemia, even in the absence of iron deficiency. So there's lots of situations where they now recommend doing a FIT test. And actually, as of this week, the NHS England guidance is to use a FIT test for all patients with colorectal cancer prior to referral And this follows similar guidance to Scotland. So they introduced it in Scotland a few months ago. And it's basically a mechanism to reduce down colonoscopies or unnecessary colonoscopies. Because FIT testing is an accurate test for colorectal cancer, particularly if you repeat it. And we don't have time to go into the FIT test. We're actually talking about it quite a lot on the main Hot Topics course. If you do want to know more about that, then come and join us on that sometime over the next few months. Irrespective, the main drive here is if we want to identify more people with inflammatory bowel disease early on, we want to do more stool tests in our patients. A FIT test is likely to be positive in someone with active inflammatory bowel disease, but don't forget it is a test for cancer, not for inflammatory bowel disease. So yes, it's decent in ulcerative colitis where you tend to get more bleeding. It's less sensitive in Crohn's, where your involvement is often higher up and maybe you don't get so much blood loss. And that introduces the risk of missing cases, particularly with this new NHS England guidance where actually some of our patients just won't end up going for colonoscopy at all. I think maybe the ongoing message here is if they've got ongoing symptoms, despite a negative FIT test, that we're still going to need to look into that somehow. So which stool test should we use? I mean, the main message is just do a stool test. And it sounds like pretty much everyone is on the same page. It's coming on the call, this clinic tonight, which is fantastic. I'd be interested to know, what have you got available locally to use? So are there any restrictions for fecal calprotectin? Do you have like an age cutoff? Is it very restrictive who you're allowed to do it in? What about FIT tests? Be interested to know the same. What's your access like where you are? And maybe pop that in the Q&A so that we can have a little look at it. It'd be interesting to see sort of like regional variation. But the main message, I think, is that in younger patients, calprotectin is preferable. They've got low risk of cancer. It's more accurate for inflammatory bowel disease. If you have older patients, then because of that increase in colorectal cancer risk, then FIT becomes more appropriate. It'd be great, I could tell you, these are some firm age cutoffs, but there is no consensus here. So I think it varies depending on guideline and where you are. Somewhere usually between 40 and 60 is your age cutoff for fecal calprotectin. NICE obviously indicates FIT should be offered for over 50-year-olds with abdominal pain and weight loss. In Scotland, they say fecal calprotectin in under 40s in persistent diarrhea. Even in that FIT guideline, they're recommending it in Scotland, fecal calprotectin in that younger group. So I don't think we should get too bogged down in this particularly. I think we just need to acknowledge that we need to do something, and there's not any kind of perfect answer. There's no absolute right or wrong, but younger users of calprotectin, older FIT test is probably the best first place to go. So conclusions. Inflammatory bowel disease typically presents with diarrhea and abdominal pain. I haven't got time to talk about extraintestinal manifestations today, but half of people with inflammatory bowel disease will get them. I've had iritis probably more than a dozen times now, which is particularly irritating. And don't forget that it may be the presenting feature, particularly if you're someone like me who's just taken ages to actually go and get their GI complaints sorted out. In the early stages, symptoms may be less severe and more vague. Differentiating IBD from other causes can be complicated. Those blood-based inflammatory markers, yes, we should still do them, but don't rely on them because they're just not that good. And stool tests are increasingly important. So let's do more calprotectin, which is the most sensitive test, more GI specific. In older patients, we maybe do FIT, but let's just be aware that that can miss IBD, especially in Crohn's. And referral to gastro, of course, is appropriate if people have ongoing symptoms, even if the initial investigations have been negative. Let's not forget that no test is 100%. Right. Oh, Siobhan, I can see there's been loads of questions and comments and things. So I'm going to hand over to you. What's the feeling of the room this evening?
Thanks, Neal. The feeling in the room is, well, lots of people have had a tiring day at work. Some people have just come back from leave. Some people are on leave. It's a bit of a mix. But we've got lots and lots of questions. So I'm going to try and address some of them. Some of them I've been answering as we go along, and then otherwise I will get back to you. What we do have is a bit of a postcode lottery for fit testing. It is not for fit testing, sorry, for fecal calprotectin. That is definitely quite variable across the regions. And some people having hoops to jump through, which in fact we used to, didn't we, Neal, in Oxford? We used to have a funny, weird algorithm that you had to answer, and we all learned to fudge those answers in order to get a fecal calprotectin, and they've now removed it. And there's somebody else saying they've got a similar one, and yeah, we've all learned to fudge the algorithm in order to get the test done. It's what you've got to do. The other thing is to complain to your biochemistry department and your gastro department as well. So somebody, this was, I've lost this down in the question somewhere. Someone was talking about, is fecal calprotectin raised in cancer? Yes, it is. So I think Neal, you might have touched on that later after that question came in. But yes, fecal calprotectin can be raised in bowel cancer. And somebody else talking as well about that difficult crossover between patients who've got, bloody stools, who you're a bit worried about, could they have cancer or could they have inflammatory bowel disease? And as I said in one of my replies, young people can still get bowel cancer as well. So if you're worried about that and you're thinking, I'm actually more worried about cancer, then absolutely to eat weight them is completely appropriate if you're worried they might have bowel cancer. And that's completely fine to do that. Young people can still get bowel cancer as well as getting inflammatory bowel disease. And we want to be careful of our, of our diagnostic overshadowing there, don't we? There've been lots and lots of questions about fecal calprotectin in children. Yes, you can use fecal calprotectin in children, but the younger the child is, the more likely it is that they might just have a raised fecal calprotectin just naturally. So under the age of 4, it becomes less accurate, and you actually want to discuss it with gastro or peds, whoever is your sort of go-to in your area, because it becomes more difficult when they're really little. But certainly for like a 5-6-year-old, I've done that and picked up a raised fecal calprotectin in a 5-year-old who turned out to have Crohn's. So yeah, it's completely appropriate to use that. Oh, someone's saying, can you talk a little bit about Crohn's in children? What sort of age should we consider this? Yeah, I mean, well, having had a child in my practice diagnosed at the age of 5, you can get it diagnosed quite early on. They tend not to present so classically with the diarrhea. It might be the symptoms of iron deficiency anemia that they're presenting with. It might just be that they're tired and grumpy and they're not, as active that they used to, and that might prompt you to do some bloods and find an iron deficiency anemia. So that might be one of the things that you that might raise it, rather than diarrhea per se. So don't be put off investigating it if they don't have the diarrhea. People talking about like bowel cancer in younger people. Deborah James would have been offered the Fit by Nice guidance. Yeah, it's really difficult, isn't it? And someone else mentioning the Never Too Young campaign. I think these are all really good things for us to have in our heads. Oh, you've just all flung in like 30 questions while I've been talking, so I might not be able to do that straight away. I might have to get back to you with that, but I'll come back to all of your individual questions. But quite variable access to fecal calprotectin. I think it is completely fine for you to empower yourself to hassle your gastroenterologist and your labs about this. It's not okay for us not to have access to this test. And certainly I'm never shy about emailing our biochemistry department and our gastro consultants when things, haven't been working well. And they need to know that there is this absence in primary care, because it's an important test that we need to do. There's someone else talking about, is there a lag effect in terms of fecal calprotectin? Yeah, it's actually a good sort of surrogate marker for mucosal healing. So if somebody has had a flare and then it's improving, doing a repeat fecal calprotectin can be really helpful to let you know if the mucosa is healing up. It's a good sort of surrogate marker for that. So yeah, that's well worth having a look at that. Okay, I'm going to stop talking, Neal, because you've got loads to talk about, and I will try and answer all these questions individually.
Yeah, thanks, Shiv. Yeah, great questions, everyone. Yeah, thanks. Siobhan's going to be kept busy for another 20 minutes, I can see. Okay, well, let's move on to section 2. So, second patient of the evening, Marcus, 38 years old. He was diagnosed with UC 14 years ago. He's on 2.4 grams of Octasa, so oral mesalazine daily, not had any flares for 3 or 4 years. He went to Turkey on holiday, forgot to take his meds, and he had an episode of acute gastroenteritis. So after that settled, unfortunately, actually, he had ongoing symptoms. So he had bowels opening 3 or 4 times a day, fecal urgency, and then he developed a bit of blood in his stools. Didn't feel like the gastroenteritis felt exactly like one of his flares. So he restarted his meds when he got home, but the symptoms are getting worse, not better. So here we've got Marcus with a flare of his ulcerative colitis. So let's do a quick poll. So would you feel comfortable with assessing and treating this flare? So A, yes, I would manage this myself. B, yes, but only with advice from the IBD team. Or C, no, I'd refer him back to the IBD team for treatment. So how would you approach Marcus? Would you sort this out yourself, or would you get the specialist involved? How are you going to approach him? Okay, let's take a look at your answers. Okay, so 2/3 would manage him, but with advice from the IBD team. Some would take it on yourself, some would refer him back to the IBD team. Fair enough. Okay, so it gives an idea about sort of where we're sitting with things. We're going to have a think about managing in flares in general practice. Half of patients with IBD will have at least one flare each year. So the big question is, can we help that group of our patients and keep them out of hospital, and can we manage it in the community? Well, that's a very firm yes. It's a firm yes, maybe. So yes, we can manage flares in general practice. There's no reason why we shouldn't, assuming that it's safe to. So it is helpful for the patient. It avoids delays in starting treatment, but we need to be selective about who we manage. And data suggests that over half of us lack some confidence in managing flares, but actually the treatment pathway is straightforward. And Crohn's and Colitis UK, in conjunction with the RCGP and endorsed by the British Society of Gastroenterology a few years ago, have put together some flare pathways which make our management really very straightforward. They're just in the process of updating their pathways. It's not huge changes, but it's little nuances that take us further along the road in medicine, isn't it? And they're due to be published imminently. So that's kind of part of the reason why they want to kind of raise awareness about this now. So we're going to do a 4-step process for managing this flare. So firstly, does this patient need referral? So complex patients require specialist input from the outset, and we don't want to be trying to manage them ourselves. So younger people, if they've got UC or Crohn's, and they've got a stoma or a fistula, they've needed surgery, or they're on biological therapy or other immunomodulators with Crohn's disease, then these are all complex patients. These we want to be putting a phone call into their IBD team. And of course, those then, if they're severely unwell, they of course also need a discussion with their IBD team, or maybe even immediate referral into the acute medical team, depending on the situation. So things like fever, tachycardia, hypotension, anemia, driven by IBD, all of those are bad news. All of these are just general markers of someone who's really unwell. This isn't rocket science. For ulcerative colitis, they also add in things like if you've had 6 or more bowel movements in a day, plus you've got 2 of these derangements in your physiology or blood markers, then that's a marker of acute severe colitis. They need to be going straight to hospital. And Crohn's disease can be more complicated because you get a variety of different sites. You also get the risk of obstruction and abscess. We need to be particularly careful with this group. So we have to decide whether we can manage them in primary care. If we can, then the next step is to confirm that it's the flare and exclude the differential diagnosis. The first point I should say for all of these is, even if we're managing them in primary care, it is worth just putting an email into the inflammatory bowel disease team so that they can at least have the fact they're having a flare recorded on their notes. That's important for when they're thinking about disease, when they're thinking about treatment and prophylaxis and disease-modifying treatments and things like that. The number of flares you're having each year is an important marker of that. So then other things to think about. Are there any triggers? So it could be a gastroinfection, could be anti-inflammatories. For instance, they can help trigger things off. Stress can do it. I mean, there's loads of things that could potentially trigger it. Are they adhering to their medications? Obviously, that's an important question always for our patients. And then if they're on anti-inflammatories, stop them, because that will definitely likely to make things worse. And then generally avoid opiates, because that starts messing up your bowels, and they have a tendency, particularly if they've got bad disease, to do worse if they've been taking opioids. And then we want to confirm the flare with inflammatory markers. So, and also exclude GI infection, because let's not forget that the inflammation predisposes you to also having infection. So we need to rule that out. And then we should do the simple blood test, like do an inflammatory marker like a CRP, full blood count, UNEs, check that stool culture. And ideally, for these patients, we'd also do a fecal calprotectin. And this is a relatively new thing. They definitely get this done in clinic, but actually it's useful for us to start that process in primary care. Gives us kind of like a baseline, well, something to compare against, hopefully a baseline that they've had at some point. The key message, though, is don't delay treatment waiting for those results. It could take days to get a fecal calprotectin and a stool culture back. So don't wait around on that. You can always stop the treatment if for some reason it looks like something else is going on. So here is a really long list. You don't have to wait for me to talk through all of this to start clicking on the buttons. But remember, we've got Marcus. He has got left-sided ulcerative colitis. He's not acutely severely unwell. He's on his 2.4 grams a day of Octasa. How are you going to manage his flare? I put a load of options down here. I'd be just interested to know how you would approach this. So not necessarily saying that there's a definite right or wrong answer, but what would you do in this situation? So we've got A, add in mesalazine suppositories, B, mesalazine enemas, C, increase that oral mesalazine to 4.8 grams a day, D, increase the oral mesalazine and add suppositories, E, increase your oral mesalazine and add an enema, a mesalazine enema, I should clarify. F, would you add in a prednisolone enema? G, would you add in oral pred? Or H, add in oral budesonide? How are you going to approach this? I know there's a lot of options on this screen right now. This is purely a reflection of we have a lot of options in how to treat inflammatory bowel disease flares, but there is, to be honest, there is a preferred way to go here. All right, let's take a look at your answers. I love it. So we have a very broad spread of our large number of options. And I actually really like it when we have this on the course, because this just shows there's actually quite a lot of uncertainty around what the maybe the best approach is here, which is great because we're talking about it right now. So the first question we need to know, and I should say that we're going to focus on ulcerative colitis now. I'll talk about Crohn's briefly at the end, but ulcerative colitis, because it's the one that we can make more of a difference with. There's a greater chance that we can deal with this in primary care. So the first question we need to know about their UC is, where is the disease? So is it proctitis? So really quite limited. Is it left-sided? Is it more extensive disease, or pancolitis? Whole bowels affected? Because that definitely influences our options. The treatment differs depending on the site. Number two, what is their current treatment? So we need to know that, because we need to escalate their treatment. They're not controlled. They're having a flare. We have to go up, basically. So worth knowing, does the patient have an existing treatment escalation plan? Some of them might do. I'll be honest, I don't think I ever have from any of my gastro appointments. So if not, then you can follow those Crohn's and colitis flare pathways. I should have mentioned actually at the start, you'll see on your screen there's the resources tab, and in the resources tab, there's links to a whole bunch of different useful websites and tools and things, including links to things like the flare pathways as you sort of go through some of them. So we want to escalate treatment, and ideally, the overriding principle is to use alternatives to steroids where possible. Steroids are at the bottom of the list. They're at the end of the line. We want to try other stuff first. So for UC, oral or rectal mesalazine is the first line. Rectal steroids are a second line. And there's a good reason for this. It's not just the side effects of steroids that we want to avoid. It's because for most situations, mesalazine is more effective for most patients. So a quick word on mesalazine. I apologize if I'm teaching you to suck eggs, but I put this in here purely because I didn't actually know much about mesalazine until I started treatment on it. And even then, it took me quite a while to realize why I was on the treatment I was on. So mesalazine is a 5-ASA. They're the same thing. It's an anti-inflammatory medication, and it's highly effective for ulcerative colitis. Not so effective for Crohn's disease, but might help with some. The important thing to know is its action is topical. So even those oral preparations are acting topically inside someone's bowel. So oral mesalazine, it doesn't get absorbed systemically. It's converted in the distal small bowel or in the colon into its active form, where it then has a localized effect on the bowel wall. Worth always prescribing by brand because formulations are not directly equivalent. There's differences between, say, Octasa, Pentasa, and Salifac. Suppositories and enemas are very effective if you've got distal disease. It's probably the best way to deliver the medication to where it's going to have most effect. They're not great at thinking about suppositories or enemas in the UK. Not something we talk about very much, but for this, they are a fantastic treatment. And again, not bringing myself into it too much, but I've got predominantly distal disease. For years, I was taking oral mesalazine, and I kept on intermittently having flares and things not getting under control. And it took a course of enemas and then suppositories to get things under control. And I now manage my condition purely on suppositories, and I've stopped oral stuff, and that's worked well for several years now. Once you get over that initial hurdle, mental jump into the world of rectal treatments, then things potentially get a lot better. So also worth knowing that adding suppositories and enemas improve the chance of remission when they're added into oral therapy, even if you've got extensive disease. So there's, I think that's probably because most of for a lot of people with UC, most of the initial inflammation gets generated more distally. And so like sort of treating that area can actually help have a knock-on effect in the other areas too. So what's their site of disease? Proctitis, then suppositories are the way forward. Start mesalazine suppositories. You've got Salifac or Pentasa 1 gram at night. Put them in at night because no one wants to be walking around with a suppository in them during the daytime. Recipe for disaster. Review their response at 2 weeks. So that's really straightforward proctitis suppositories. If they've got other disease, so left-sided, extensive or pancolitis, then firstly maximize their oral dose. So for Asacol, Octasa, Mesavent, you go up to 4.8 grams a day. That's the maximum dose. For Pentasa, it's a different dose. It's 4 grams. That's the max. And Salifac is 3 grams. It's relatively uncommon that they would be on that higher dose for maintenance, although not impossible. But for most people, there's probably a little wiggle room there that we can go up. Then offer them rectal therapy as well. So particularly if they've previously had an incomplete response to oral 5-ASAs, and particularly if they've had rectal therapies before and it's made a big difference, definitely it's worth doing. So then you've got two options. You've got mesalazine, so Salifac foam or liquid enemas, 2 grams at night, or Pentasa liquid enema, 1 gram at night. I've done many months of these, and enemas are not that great. I mean, they are fantastically effective treatments, but they are pretty tough to tolerate. Just on a light-hearted note, it reminds me of a Billy Connolly joke, which is never trust a fart. If you've got a patient who's on enemas, then that is they may not appreciate that advice, but I think that would be that is useful, a useful heads up for various reasons, because it's hard lying on a bathroom floor at night time and filling your rectum with foam enema, and then trying not to poo it out. That is quite an unpleasant experience. It's painful. It's hard. You wake up in the middle of the night and you've forgotten you've done this, then you could be in trouble. Back to that Billy Connolly joke. So some people won't be able to tolerate that, in which case they can try locally acting oral agents such as oral budesonide or oral beclomethasone. I suspect by that point we might want to be getting the IBD team involved rather than initiating them ourselves, but they are part of the pathways. And then again, review at 2 weeks. So at 2 weeks, if it's getting worse, they might need to go in, phone up gastro or the IBD team and have a chat. If they're getting better, just keep going for 8 weeks, and then always remember to continue some maintenance after that flare therapy for 8 weeks. So what dose you need to prevent a relapse, and then encourage them to just keep going. It's a lifetime treatment. They need to take it regularly. No response, then they may need steroids. And I don't want to spend a lot of time talking about steroids because it is the bottom of our list when we're treating people, but just a kind of quick note on them. So if at all possible, let's avoid, but sometimes they are necessary, and oral steroids in particular do work very well. If you're on more than one course a year, you're going to need steroid-sparing therapy. And remember, most bone loss on oral steroids happens within the first few weeks or months, so start it straight away. Start it when you start the medication. Don't wait. If you're prescribing, obviously let the IBD team know, and we'll have informed them hopefully that they're having a flare, but tell them they're having steroids. And then when you're prescribing, so we prescribe prednisolone, and it's 40 milligrams for a week, and then you reduce down by 5 milligrams every week until you reach zero. So they're going to be on that for 8 weeks. And it's worth prescribing the exact number of tablets, so 252 tablets for a complete course, so that patients don't stockpile. Because I mean, I've been there. It's very tempting to do this. It's very tempting, if things seem to go wrong, to just have a bit of prednisolone because it sorts things out. But of course, if people are doing that, then that's putting them at risk of all the side effects of your osteoporosis, avascular necrosis, all the other things that we know about with steroids. And then if you're starting steroids, review them once again at 2 weeks. If they're not improving, get in touch with the IBD team. If they are improving, keep going. And then remember, they need that ongoing prophylaxis. So what about Crohn's? Often more complex. So most routes for Crohn's basically require a discussion with the IBD team or immediate admission. So be very cautious in people with Crohn's having flares. And don't just chuck steroids at them because they're at high risk of having an abscess. You give them steroids when they've got an abscess, that can be really bad news. It's a contraindication. It can be quite significant. So in conclusion, we can manage flares in the community. More complex patients need specialist input. We exclude acute severe disease, and then we need to just have a little think about where we go next. So confirm that inflammatory flare, and then think what's the site and what's their current medication. We've got those flare pathways, which are very, very helpful. Or if they've got a treatment escalation plan, fantastic, let's follow that. Avoid steroids where possible. For ulcerative colitis, mesalazine is the treatment of choice. Reassess at 2 weeks. They might need steroids if they're getting no response, and referral if they're deteriorating. And always, always, always remember, just ping off that email to the IBD team to let them know that flares happen. What do we do with Marcus? Well, he's not acutely severely unwell. His current meds were 2.4 grams of Octasa. He's got left-sided ulcerative colitis, so we confirm he's got a flare. We rule out GI infection, and we escalate treatment. So Octasa, up to 4.8 grams a day. He's previously benefited from from rectal therapy. So we added mesalazine enemas, so he can have Salifac foam enema, 2 grams each night for 8 weeks. We review at the 2-week mark, and things are getting better, which is the most likely course of action for him. It's not perfect yet, but is definitely much, much better. So keep going for 8 weeks, and then you can go back to probably that maintenance dose of Octasa for him, because he's been well controlled on that for quite a long time. And always remember, email IBD. Right. Siobhan, any questions?
110.
In fact, before I let you go into the millions of questions that you've obviously got, for everyone else, whilst Siobhan's talking about that, I'd be interested just to know, we'll do a bit of rapid reflection before we go into the last couple of slides. So just post maybe 1, 2, 3 learning points in that Q&A box that may be of interest from this evening. I'd be interested to know what areas you found interesting. Right, Siobhan, sorry, I didn't mean to interrupt.
Thanks very much. I'm going to gather a few themes because there are so very many. Quite a few, actually, the same thing about waiting for somebody's results. We don't have access to quick for same day results or next day results. So the answer here is absolutely treat the flare. You do not need to wait for the results. If symptomatically somebody is describing a flare and you think that they have a flare, and obviously physically you might be examining them as well, then don't wait for the bloods, just crack on and treat. Lots of people asking that. So yeah, you absolutely feel free to just keep going. Be aware of young people tolerating significant illness. That was certainly my big lesson as a parent with my then 17-year-old who got admitted with acute severe colitis. Embarrassingly, we were only going for a clinic appointment. And neither of us really realised how unwell she actually was. In fact, she had an anemia of 80 and a tachy of 120 and was really quite poorly. And I've actually come across a couple of sort of late teens tolerating marked anemia for quite a long time. So just being aware of that. A few questions about meds, about sulfasalazine and things. And just one thing just to sort of be aware of is about pre-pregnancy counselling, both for men and for women, because if you've got a man who is taking sulfasalazine, that can affect sperm count. Methotrexate is teratogenic in both men and women. So just being aware of that in your patients. And Neal touched on this about with Crohn's, because there's been a few questions about Crohn's flare-ups. Crohn's flare-ups, by and large, we want to be on the phone to somebody. They're much more difficult to manage. You've got to be super careful about abscess formation, and we want to be really thinking about sending those patients in, or definitely getting advice on the phone, because they're just much more likely to be more poorly, have fistulas, abscesses, and for things to sort of go wrong, basically. The questions are now coming in so fast that I actually can't read them, but I think this is mainly feedback. Somebody else mentioning that, Neal, about in their experience, it can be pretty hard to hold an enema when you're poorly. And somebody else asking, I'm going to ask you this actually, about when you decide when you're going to use a suppository and when you're going to switch to enemas. Is this just more about the extent of their disease, or if you've already tried the suppositories and they're not working? I'd be interested in your opinion on that.
Yeah, I think it's more about just the position of their disease. So, I mean, if it's anything other than proctitis, then they're going to need to have an enema. The only thing is, and I fell foul of this, I ended up having treatment with enemas for months, and it never quite got on top of things. And it was because the enemas are so effective at shooting it up into your rectum and sigmoid colon that it actually it can miss the very distal part of the rectum. So then sometimes people will also need to have a suppository as well to actually get complete control, because it's that distal part that actually drives a lot of the inflammation. So for me, I actually used months of treatment when I didn't need to. I'd sort of misunderstanding about how to effectively control things. But if it's just proctitis, then suppositories are actually, almost always they're going to be just fine. So it's all about position. Right.
Yeah, that reminds me actually about one of the other things that's helpful to be aware of is the issue of proximal constipation, which sometimes people can get. And it means that the topical therapy that they're taking by mouth, but we're waiting for it to work as a topical agent, whether that's budesonide or your mesalazine, gets stuck. It gets backed up, doesn't it? Because they've got proximal constipation. So often worth just sort of checking up with that, because we're so used to patients having diarrhea, we may not ask about that as well. Sorry, I'm looking at the time. Yeah, I'll stop talking.
That's a very good point. And so another big tip, if people are getting constipated with things, then the gastro team often recommend golden linseed. So you have like a tablespoon of golden linseed, just drink it down. And that over a few days helps them sort out the constipation. But that's a very good point. As you can see, guys, we could spend so much longer talking about this. I feel like we're really, an hour is not enough, quite clearly. We've barely scratched the surface, but we need to finish with the rest. So don't forget other issues. This list is not exhaustive. Extraintestinal conditions can be very problematic for people. There's issues around colorectal cancer risk and surveillance. Fatigue is very common in any inflammatory condition. Nutrition is difficult sometimes because of poor absorption. Stoma management is a whole other area. Contraception, fertility, pregnancy, all of these are big issues as well. There's loads of really good resources. So on the RCGP website, there's their IBD toolkit. It's free to access. You don't have to be a member. That's got some really great resources there. And Crohn's Colitis website has got some great patient and professional resources too. So do check that out. Someone just saying, are the resources on our NB dashboard? No, I don't think we've got the functionality for that, but this is recorded and you'll be able to continue watching this. So you'll be able to go on to the resources section and get them. A few things just to highlight. So Crohn's and Colitis UK are currently doing a public awareness campaign, or is just starting in a few weeks rather. So we may see an uptick of patients coming in thinking about inflammatory bowel disease. So it's good that we're getting our heads around it now. They're also publishing a symptom checker. So patients can go on and have a look at whether they should be concerned about their symptoms, and indeed when they shouldn't be concerned about their symptoms. So I think it is a helpful thing. Also, they're trying to get people, they've sent a letter out to GP practices, but they're really, really keen to try and get a survey from us as healthcare professionals in primary care about what we would find useful for that from them to help with us managing patients with inflammatory bowel disease. So if you do have a moment, whether now or after, do have a look at, just follow this QR code. It's also in the resources tab. Just as a very quick survey, that would be really, really useful if you've got the time for that. Thank you so much for putting all your learning points in here. So, there's basically a bit of everything. It's great. Someone's taken something out of everything. Do more fecal calprotectin tests, use for them in children, but be mindful about stuff. Make sure you email the IBD teams. Yeah, it's great. Mesalazine, not absorbed. Don't use steroids. Yeah, this is all good stuff. So fabulous. Look, I think we're just past 9 o'clock, aren't we? So when we finish, you'll see this little box come up. As you know, anytime we do one of our courses with MB Medical, we're always keen to try and get your feedback so we can improve on the course. So if you've got time to do our survey, different from the Crohn's and Colitis one, then please do that. It's very, very quick. And it just remains for me to say thank you so much for joining us this evening. It's fantastic. We've got well over 400 people this evening. Thanks so much for joining us. Thanks for keeping Siobhan busy. Thank you, Siobhan, for keeping everyone going this evening. And at that note, I better sign off. Have a lovely evening, everyone. Let's go and watch the Bake Off.